Hello, my name is Shan Liu. I'm at Massachusetts General Hospital, and today I'll be talking about the myth of the mechanical fall. So it's a busy ED shift, as we all have had every day, and a 74-year-old patient comes, according to the triage note, with the triage note saying they came in after a mechanical fall. You think, great, they twisted their ankle, all we need is an x-ray, easy disposition, and out the door, right? Wrong. I'm here to tell you the first thing you need to do is understand that the term mechanical fall is an awful term. The question you need to ask yourself is, what do you mean by the term mechanical fall? What does the triage note mean by mechanical fall? And why do you use that term? Do you mean that the patient tripped on a rug and fell? Do you mean that they slipped on ice? Do you want to make sure that they don't have a syncopal etiology to their fall? And God forbid they have to be admitted to the medical service? The term mechanical fall really has no basis in scientific terms. In essence, it sort of invokes the idea that a bulldozer or some kind of external force pushed this patient over and they wouldn't have fallen otherwise. And basically it has no meaning in terms of what actually is the etiology to the fall. We did a study of 400 patients and found that there's no definition or agreement amongst our colleagues for the definition of what a mechanical fall means. Some meant that the knees buckled, some meant that the patient didn't have any lightheadedness or dizziness and didn't have an etiology that was cardiac. So the idea is that there is a myth to this. The myth is that patients who have mechanical falls are not as sick as those patients who have non-mechanical falls. And the truth of the matter is, based on our research, is that there is no difference in adverse events at 6 months. We found that the recurrent fall rate, the hospitalization rate, and the mortality rate at 6 months was exactly the same between the two groups. So in essence, the term mechanical fall is ambiguous and has no prognostic value. In essence, it's a garbage term and should be thrown away. One thing I do know, and that what the take-home message is that falls are sentinel events and deserve sentinel responses. So if there's one home take-home message from this, is that there's a reason why that patient fell, and it is very complex, and there's multifactorial reasons for that patient, why that patient fell, and it is our job to prevent the next fall. What we do know is that falls have high adverse event rates and mortality rates. Approximately 12% of our patients in our studies die within 6 months, and the CDC just noted that every 20 minutes an older adult dies from a fall in the United States. So what can we do? The American Geriatric Society recommends a multifactorial risk assessment that includes these risk factors, such as medications that increase the risk of falls, gait and balance, mobility issues, neurological impairments, and orthostatic hypotension. Our own geriatric emergency department guidelines also recommend a multifactorial risk assessment and a targeted intervention based on this risk assessment. These algorithms are often time-consuming and complex, but if you can take 5 things home that you should do in your evaluation for these patients, it is these 5 things. One is examine the fall event and the history of falls. Minimize any medications such as opiates or benzodiazepines or psychiatric medications that increase their risk of falls. Look at their gait and refer them to physical therapy if needed, as well as an exercise class, and do a home safety evaluation referral with case management. This is a picture created by Chris Carpenter at WashU, which also shows environmental risk factors as well as intrinsic comorbidities that patients may have, such as dementia and cardiac etiologies to their falls. In terms of the physical exam, watch this patient walk before you discharge them. If they can walk 3 meters and return to their chair in less than 14 seconds, then they do not need a physical therapy evaluation. But if it takes longer than 14 seconds, then refer them to physical therapy either as an outpatient or in the emergency department, because they are at high risk for falling again. Know that falls can be prevented. Approximately 30% of falls can be prevented, and it is our job to prevent them. We recommend also that patients get regular vision checks, that they have a discussion with their primary care doctor to decrease the side effects from any prescriptions that they may have, as well as wear safe shoes that have traction and decrease their risk of falls. If there's anything like a pill to prevent falls, it is to prescribe exercise. So get your patients that are older into group classes such as yoga, tai chi, balance classes, and of course, step classes like this. Another resources, the ASEP website has a 7-step challenge to prevent falls, which was a video that we created with their funding to help you give resources to your patients, and they can actually watch this video on YouTube while they're waiting for their x-ray. And in the end, just describe the fall. Do not use an ambiguous term like mechanical, and just describe the true event. Thank you.